correct. When I am working as a physician now, is part of a corporate. It's under the structure of a corporation called Kozarsky Consulting.
Okay. And back in 2022?
In 2022, it was my services as an aviation medical examiner were part of Kozarsky Consulting.
So any services that you receive from Delta employed pilots for AME or HIMSS AME services would be paid for by the pilot. Is that correct?
The credit card payment or check is made by the pilot. I was gently persuaded to add becoming an aviation medical examiner to the things that I was certified to do. And I was very happy to cave in and say I would do that. I believe that the designation had already been partially negotiated even before I formally requested the designation. So the position was open. It involved aviation and medicine, so it was something that I was happy to do.
I'm sorry, so you were gently persuaded by whom?
I had a group of pilot friends in Cartersville, Georgia, and basically they did not like the choice of AMEs, aviation medical examiners, they had at that time. I had a very close aviation relationship. Many of those people were my post-operative eye patients, and they basically said that I should become an aviation medical examiner, and they had had information that a designation was possible in the Cartersville area, and it was an attractive possibility to me. If the pilot reports that he's not going to as many, he's cut back on the number of AA meetings that he's going to, et cetera, and I can give some gentle advice. I'll give advice as long as they're within the qualifications and requirements of their special issuance letter. I don't think I've ever had any of the HIMSS substance pilots talk about insomnia. I would talk to them. I would tell them, number one, I would refer them to their primary care doctor.
Have you ever had a situation where a pilot discloses to you symptoms of a serious health condition that have not yet been diagnosed?
Yes, sir.
Can you describe those situations?
A pilot could describe issues that are suggestive of coronary ischemia, coronary-related symptoms prior to FAA disclosure.
And you've had actual instances of that?
Yes, sir.
And what action did you take in response to the pilot describing those issues?
I refer the pilot to a cardiologist, and I take their FAA application and write down why I am deferring the decision, which would include that reason, and transmit it to FAA without issuing a certificate. Sure.
No, I'm asking about health-wise. If someone has blood pressure that almost disqualifies them, do you give them any advice as to how to avoid the disqualification?
Basically, that might be followed by, it might be a good idea to have that checked by your primary care doctor, treated if needed, and follow up there. That would be the general advice, assuming that it's still a qualifying blood pressure.
In terms of your function as a HIMSS AME, you supplied your own instruments, tools, and place of work for the performance of your duties, correct?
Yes.
And you set your own fees for the performance of your duties, correct?
Yes.
And you're generally paid directly by the pilots you serve as either an AME or HIMSS AME, correct?
Yes.
And you never had an employment relationship with the FAA or any other federal agency, correct?
To answer that completely, as a federal air surgeon consultant, I am paid on a per case basis in that role by FAA.
Okay. And with that exception, would the answer be that aside from that, you have no further employment relationship with the FAA or any other federal agency? Is that correct?
Yes.
So you would talk to Dr. Lin. Dr. Lin is a psychiatrist,
He is.
and you would tell the pilot, let's consult with Dr. Lin to see if this is a problematic occurrence.
I would try to do that.
And as HIMSS AME, what is the proper response to indications of emotional dysregulation, such as irritability, anxiety, depression, anger, and loneliness?
It would have to be quantitated, and if I thought it was significant, I would talk to the pilot. I would definitely have them make a visit to Dr. Lin.
Okay, and the source for any information about emotional dysregulation, as I've described it, could be from the pilot himself in the course of your meetings with him. Is that right?
Yes, pilots tend not to be a disclosing group in general, or it could be secondary information as well.
Okay. Or could it be something that you just observe? Or do you have the power or the capability to observe in your meeting irritability, anxiety, anger?
That a pilot is an obvious emotional distress? Yes,
Yes.
I think that's something within my capability of recognizing.
And would you keep that observation hidden from the pilot, or would you disclose that to the pilot that is your observation?
I try not to hide anything from a pilot in terms of my observations or thinking or actions.
Now, sleep disruption, social withdrawal, loss of interest in activities, poor self-care, they all could be early indicators of a potential for relapse, correct?
I would imagine yes.
And would it be the same approach that we discussed in terms of emotional dysregulation, that if the pilot disclosed those elements or you observed those elements, you would discuss it with the pilot and urge him to consult with the psychiatrist?
Yes.
Okay. So sometimes you might be simultaneously advising the FAA and sometimes not, depending on the degree of the danger.
This, again, yes. The pilots are instructed to contact me if they have any concern that a prescribed medication or over-the-counter might have an effect on recovery or on testing. I give good common sense advice to my pilots. That's my goal.
You billed Mr. Barnard for your services, correct?
Yes.
And he paid the invoices to you directly, correct?
Correct.
And with respect to your performance of your services as a HIMSS AME for Mr. Barnard, you did not have a contract with anyone other than Mr. Barnard, correct?
Correct.
And you identified yourself to Mr. Barnard as medical doctor, isn't that correct?
Yes. Recollection is that we did talk about issues regarding his divorce, his daughter far away, going to Korea. There were aspects of his family life. I think he was involved in some business with his girlfriend. So I do have some specific recollection, some random recollection. I recollect certain things, but not a whole bunch of specifics.
Okay. Were any of the specifics you recollect a source of concern to you?
Yes, minimally.
And did you identify your concerns to
They
Mr.
were
Barnard?
already identified concerns about the dissolution of his marriage, whatever level of anxiety that was causing for him, whether it was on a trend towards getting better, whether the anger level was improving, whether he was reconciling with his daughter. And I was watching that trend line, but so were the other experts.
But did you discuss with Mr. Barnard your observations and your perception of the trend line?
We had general discussions, yes.
And did you advise him he should have caution or self-monitor with respect to any of these issues?
I was not giving out psychiatric advice at that point. I was more a listener.
And you never stated to Mr. Barnard what your reaction was to any of these incidents?
I was more a listener.
You might have been more a listener, but that was not my question. My question is, did you ever express a reaction or an observation to Mr. Barnard concerning any of these incidents?
Yes, probably.
What was most pertinent?
Mr. Barnard's most pertinent was the status of his dissolving marriage and his daughter, and I know that that was a source of a lot of his emotional distress in the past. So I know that at least at some level I inquired about it.
During the time that you functioned as Mr. Barnard's HIMSS AME, do you know whether Mr. Barnard was receiving treatment as a patient from any other licensed medical physician with respect to his alcohol-related health issues?
He may have been.
I'm asking, do you know?
I would have to look back at his records. I did at that time.
Okay. But as you said here today, you don't know one way or the other?
No, sir.
Now, your in-office visits with a pilot in the HIMSS program generally include a routine medical examination consisting of checking vitals, blood pressure, EKG tests, eye tests, and other examinations, correct?
Yes, sir.
And anything that I left out from that laundry list?
There are other parameters that we check.
Well, such as?
Abdominal, palpation in terms of alcohol and liver, general inspection of the eye, palpating, just the general physical exam. But as related to an FAA medical examination, I will sometimes say, how are things going? Are you doing okay? Sometimes anything you want to talk about.
Now, it would be your view that that you would have no duty of care toward a pilot whom you are serving as an HIMSS AME, correct?
Correct. The question is, would I be liable for stupid and harmful advice? Yes.
Now, in other contexts, you have described Mr. Barnard's PEth test in October as a negative. Isn't that correct?
I may have, if you give me the context of that.
Well, would you agree that that would be an appropriate term to apply to the results reported on October 14th, that the result was negative?
That is an accurate description of the result.
So as you sit here today, you don't know how you learned about the PEth test result in October 2022. Is that correct?
I cannot tell you with confidence how I first learned of that PEth test result.
Did anyone in that, can you identify anyone who used the term sub-threshold in communicating the test result?
I cannot definitely identify whose term that was.
So there's no basis for concluding that that term was anything other than an invention of yours,
Object
correct?
to the form.
The answer is I don't know the source of that term, but I will say that the term is accurate.
Okay, I don't
And
want to get
that's,
into
I wouldn't,
argumentation.
I wouldn't put anything that's not accurate in that email, and that is an accurate term in this, in this context.
Before we get into the question of whether it's accurate or not, I'm trying to understand the source. But you have no recollection that either the laboratory that performed the testing or anyone from Choice Labs used the term subthreshold, correct?
I have no recollection.
But are you do you believe it might have been one of the three psychiatrists that you spoke to that used the term subthreshold?
It might have been one of the psychiatrists. It might have been Dumsdorf. It might have been Michelle. I don't have any recollection.
Or it might have been something that you originated as a term?
If it was, I will own it and say that it's an accurate description. I don't recall. It was accurate enough to put it in my email.
Can you identify any HIMSS AME training that used the term subthreshold as synonymous with a negative test?
I do not recall.
You would agree with me that the statement that Mr. Barnard had a low-level positive PET test is false, correct?
Low-level positive is false, correct.
And you know that the FA representatives understood your reference to subthreshold to mean a low positive result. Isn't that true?
No.
You've never learned from anybody that the FA understood your subthreshold reference to mean that Mr. Barnard had actually received a positive test result?
I've actually heard that in their notes, it may have been, there may be a typo, or it appears that way, but that was never conveyed by me.
Have you taken any action to communicate to the FAA that in fact the PEth test was negative for the October PEth test?
I have conveyed to Dr. Dumsdorf and others that it was sub-threshold negative.
Well, okay, not sure you're answering my question. Did you ever communicate to the FAA that the PEth test result in October 2022 was negative?
I have no recollection.
And in terms of PEth testing, the cutoff level for dividing positive from negative is 20 nanograms per milliliter, correct?
Correct.
You never made any effort to obtain the actual quantitation from the laboratory for the October 2022 PEth test result, correct?
I actually asked about it at some point. I may have talked to Michelle about it at some point, but my understanding was that you pick a cutoff point and then it's either above or below that level per the laboratory.
Did you have any? Sorry, I'm sorry. Finish your answer.
That's it.
Okay. So you ask, your testimony is that you asked Michelle Gable for the quantitative result. Is that correct?
I asked, it may not have been with Barnard, but it may have been with someone else, but I've asked her about that result.
Would you agree that the quantitative analysis for the PEth test in October 2022 would have provided relevant information?
Well, if the, again, I'm going to say here that I don't have enough knowledge to know.
Haven't you expressed a wish that you had access to the quantitative information?
Again, I wish that our threshold was 8 and not 20.
Why do you say you wish that there was a lower?
Because we're running an abstinence program. Abstinence is the requirement for the FAA. It's the requirement for Delta Airlines. And why we test at 20, I think it may have been chosen, and that may have been the only time, but that may have been the only thing available, but I would have wished for 8 or lower if that was reliable and available.
Well, isn't 20 nanograms per milliliter for a PEF cutoff? Isn't that the industry standard?
Go ahead, Dr. Kozarsky.
I don't know the industry standard. It just makes sense to me personally that in an abstinence program you would use a lower threshold if available.
Do you understand that cutoffs are in drug testing and alcohol testing are designed to prevent false positives and the needless destruction of people's lives?
Objection. Argumentative. Go ahead.
I understand the thresholds are to have the most effective surveillance, particularly in a safety critical program.
So it's not, you have no understanding that cutoff levels are designed to prevent false positives?
Cutoff levels are designed to decrease false positives. I'm not aware that that would be a concern with PEth testing.
You don't have any knowledge one way or the other, whether it would have an effect on PEth testing, correct?
My understanding that at either 20 or at 8, the concern about false positives would be somewhere between 0 and minuscule.
And what do you base that on?
Basically, the specificity of the PEth testing.
No, I'm asking what's the source of you referred to an understanding. What did you read a treatise? Did you have a discussion with somebody?
I believe that I've probably thought about it, researched it a little bit, just doing Google searches and whatever. This was 5-6 years ago, and basically became fairly convinced that this was a very highly specific test.
Can you identify any treatise that you read?
Not 6 years later, no.
And the October PEth test provided no evidence of relapse, correct?
The October test was a negative PEth test at 20 nanograms.
And you don't know whether it was the result was 0 nanograms or 19 nanograms per milliliter or anything in between.
Correct.
This reference to a low-level positive PEth test, that's not a typographical error, is it?
Yes, it is.
Well, you think someone just hit the wrong keystroke or had the wrong understanding of a communication?
They should have put in subthreshold. The reason why I'm saying that is that if it were suprathreshold, if it were positive, then the communications to Barnard and all of the actions taken by FAA would look different.
This low level, a low level positive PEth test would essentially be proof
Relapse.
positive.
It would be relapse.
It would be relapse, correct?
It would be relapse, where I believe they called it something other than relapse. If they knew it was relapse, they would call it relapse. They did not call it relapse. Therefore, somewhere internally, FAA self-corrected.
So, to your understanding, the dilute analysis bears no relation to whether Mr. Barnard might have been tampering with or substituting his urine specimens. Is that correct?
No conclusion, just that dilute urines, albeit negative, are an issue as far as the sensitivity of the test is concerned.
Okay. So the dilution issue goes to the reliability of the test result rather than substantiating any suspicion about the pilot's conduct. Is that a fair statement?
To us, it's not directly behavioral. It decreases the value of the test in a recovery setting.
So your sole point of contact in terms of any questions of interpreting test results or the identification of any issues related to test results, that would have been Michelle Gable, correct?
Correct.
Okay. Did you ever have discussions with Mr. Barnard about making choices that would increase or decrease his creatinine?
I don't recall. Generally, when there are creatinine issues and dilute issues, Choice Labs is pretty good about bringing that to the pilot's attention and dealing with it.
Now, your testimony goes on to say, but 2 or 3 and earning a PEth test as a result of that is something that is often handled very, very well by Michelle, and she solves it on her level quite frequently. Was that accurate testimony?
Lots of times that occurs. Yes, I agree with my testimony.
She goes on to say, because diluted samples can be looked at as adulterated samples, or we just have to clear it's for their safety. Question, okay, so for his safety, if you recall, when he had a dilute, did you send him for a blood test for his protection? Yes. Question, okay, and did any of the blood testing that you did, is that PEth testing that you would have done? Yes, that is PEth, P-E-T-H, and those were negative. Question, okay, so he would have had the dilutes, and then for his protection, you would have sent him for the PEth testing, and all those were negative. Answer at line 10, correct. Now, is there anything in Ms. Gable's testimony that comes as a surprise to you?
No. That in what she said, she is correct.
Let me refer you back to Exhibit D, your final sentence in your communication of October 14th, 3 days before the special issuance was revoked. The sentence reading, the motivation to purchase of beer or beer-like beverage, whether alcohol containing or not, if alcohol containing, whether intentional or not, as well as 3 recent dilute urine specimens, is suggestive of imperfect recovery. Wasn't it your intent in referencing the 3 recent dilute urine specimens here to suggest that the 3 recent dilute urine specimens was suggestive of imperfect recovery?
No, my intention was to provide complete context for this whole event, which is what they asked in the summary document, other than the fact he's very difficult to test, but it brings up the thought is there could be an evasive or avoidant behavior here.
I'm trying to get an answer to the question of why you put in 3 recent dilute urine specimens.
Because it's part of the picture.
Okay. And it's part of the picture which, in your view, indicates that there was some effort to evade the recovery and the detection and recovery process.
Right. Yeah.
Is that yes?
The answer is, sir, I don't know the answer to that.
Did you ever reach out? So I'll broaden the question. Did you ever reach out to anybody for assistance in interpreting any one of these negative dilute results or the 3 negative dilute results collectively?
No, sir. Not that other than whatever communications I might have had with Michelle Gable, no.
Do you recall Michelle Gable, any communication from Michelle Gable indicating how those 3 test results should be interpreted?
I have no recollection.
Well, Michelle Gable never brought any issues to your attention with respect to Mr. Barnard's testing as being problematic. Isn't that correct?
No. She may or may not have told me when he had triggered a PEth test after a dilute. I don't expect that I'd have any recollection of that specifically, but she may well have.
And your view was that just your view was even if he had just purchased a no alcohol beer-like beverage, that was evidence of a potential relapse, correct?
No. So the answer is he gave me a scenario that I had never seen before, and I called in the cavalry as far as all of the potential meaning and who had to be reported what. This was a novel situation.
Going back to your October 14th communication to Dumpstorff and Chesnow, that last sentence we've been looking at is the first clause is the motivation to purchase of beer or beer-like beverage, whether alcohol containing or not. So it was your view that that the motivation to purchase a beer-like substance, even if that beer-like substance or beverage contained no alcohol, was indicative of relapse?
No, sir. It's concerning. It's not relapse. Is it pre-relapse behavior? That's up to bigger brains than I have in addiction.
So, but my question, and the answer is no, it's fine. Did you ask Mr. Barnard if he had received any instruction with respect to the consumption of non-alcohol look-alike beverages being contraindicated?
I don't recall asking him specifically.
Did you ever direct Mr. Barnard in any of your consultations with him that he must abstain from zero alcohol beer products?
Did not come up in routine conversation with Mr. Barnard prior.
Have you ever seen any written material, either out of Talbot or out of the Delta HIMSS program, advising pilot participants in the HIMSS program that they should not buy a zero alcohol beer-like beverage?
You know what? I haven't seen that, but I haven't seen the instructions on how to get to the bathroom either.